Welcome to Deuk Spine Institute, and our live stream today involves a patient who traveled here from California. Now, she injured her lower back a long time ago. You can see from the x-ray she has fusion done at L5S1. Can you see that metal?
Yes, we can.
There's also a giant cage where they replaced her disc with a metal cage. So she's fused at L5S1, however, she now has problems above at L45, and that's where her pain is coming from. We call this adjacent segment disease. It means you had a fusion, you lost the movement in your spine. You can see the scars from her fusion, they're huge. And right above the fusion, she has pain that's coming from adjacent segment disease. Now, I think she never had a stimulator, right? No. If you have questions during this show, please feel free to ask. I'll do my best to answer for you. In the meantime, Henry, let's share with our audience how patients with back pain can tell what's causing their back pain. There are 30 causes of back pain, and they're all identified in this animation. Let's show our 30 different causes of back pain. John? I'm Dr. Deuk with the Deuk Spine Institute, and we're going to discuss 30 causes of chronic back pain. Chronic back pain is back pain that lasts longer than 6 weeks, and there are 30 causes of chronic back pain. The most common cause is going to be a disc injury. Disc injuries such as disc herniations, disc bulges, disc ruptures, degenerative disc disease account for 86% of chronic debilitating back pain, and they are totally fixable with the proper treatment. The best treatment for disc injuries is Deuk laser disc repair. Let's take a look at the 5 lumbar discs that can be injured. The most common disc to be injured is L4-5, followed by L5S1, then L3-4. The L1-2 and L2-3 discs are far less commonly affected. Next, we have facet joints. Facet joints are small joints located behind the discs in the back of the spine. There are 10 facet joints, each paired left and right, L1-2, L2-3, L3-4, L4-5, and L5S1. The most common facet joints to cause chronic back pain are L4-5, followed by L5S1, followed by L3-4, in that order. After the facet joints, which account for approximately 10% of chronic back pain, we move on to the sacroiliac joint. The sacroiliac joint accounts with the piriformis muscle for approximately 4% of chronic back pain. The sacroiliac joint is a joint located between the tailbone or sacrum and the iliac bone. There is a left and right sacroiliac joint. In this diagram, you can see the joints turning red, indicating inflammation and pain either in the left or right sacroiliac joint. These sacroiliac joint injuries and pain can be treated most effectively with the Deuk plasma rhizotomy of the SI joints offered at Deuk Spine or Deuk Joint Institute. The fourth most common cause of chronic back pain is a piriformis muscle injury. The piriformis muscle is located in the buttock, and there is a left and a right piriformis muscle. The muscle gets torn, unfortunately, when people bend the wrong way. This usually occurs in patients with orthopedic problems such as hip pain, knee pain, or back pain. By bending improperly, they put the muscle under too much stress and they tear the muscle. The torn piriformis muscle causes severe debilitating pain in the top of the buttock. There is a left and a right piriformis muscle, and this can be treated most effectively with the Deuk piriformis muscle release. This is performed percutaneously with a 4mm incision. The sciatic nerve does run through the piriformis muscle, and many patients with piriformis muscle syndrome also have sciatic pain down their legs, with pain, numbness, tingling, and weakness in the leg that's affected on the side of the piriformis muscle. Piriformis muscle can be treated with injections such as steroids, Botox, PRP, or stem cells. However, those injections always wear off and the patients end up coming back with the piriformis muscle pain that reoccurs. The most definitive treatment for permanent relief of piriformis syndrome is a piriformis muscle release. Next, injuries to the bones of the spine, touches the vertebral bodies. With trauma, can cause fractures of the vertebral body. Vertebral body fracture is diagnosed with X-rays or CAT scan or MRI, and they're treated with injection of cement into the vertebral body. Looking at the vertebral bodies, the most common to be affected is L1, followed by L2, then L3, L4, and L5. The sacrum can also be fractured. Finally, the coccyx is the last cause of chronic back pain. You can see in the diagram the red coccyx at the bottom. This comes usually from an injury where the patient falls on their bottom, sustains pain at the tailbone, and this can be treated with injections of the coccyx ligament. These are the 30 most common causes of chronic debilitating back pain, the most common being the disc, causing 85% of chronic back pain, followed by the facet joint, causing 10% of the chronic back pain, followed by the piriformis muscle and sacroiliac joint, which cause 4% of chronic back pain, totaling 99% of chronic back pain, which is totally fixable and curable with the right treatment. Thank you. I'm Dr. Deuk Majin. Thanks for joining us. Welcome back. You can see from our video there are 30 very specific causes of back pain, and Deuk Spine Institute is the first in the world to ever discover these 30 causes and publish them. We've been showing these 30 causes to you for quite a while now. In this patient's case, her back pain is coming from the L4-5 disc. I just tested it using a discogram, and it was 10 out of 10 pain. Sean? So where is the pain coming from exactly? Well, you watch the video, you can see when back pain comes from a damaged disc, it comes from a tear in the back of the disc called a posterior annular tear. By itself, the posterior annular tear is not painful, but when you get inflammation in the tear, that's when it becomes painful. What causes inflammation is the herniation of the nucleus pulposus out into the tear. So the trauma that caused her injury to her disc injured two things. It tore the annulus and it crushed the nucleus next to the tear. And now with normal activities like shopping, bending, gardening, she's pushing fragments of nucleus out into the tear, and that's causing an inflammatory response, which is very painful. The entire surgery is done through a 7mm incision. You see that, Henry?
Yes, we do.
And I use a scope, an endoscope, to do the surgery. It's good, Luis. The endoscope has irrigation, a light source, and suction on the tube. It also allows us to use instruments through the small diameter channel in the middle of the scope. All right. If you have questions, feel free to ask me. Happy to answer them. We're fixing one disc. She also has hip pain. We're going to do a Deuk plasma rhizotomy on her hip. I don't know if you have that video, Henry, but it'd be kind of cool to show the DPR video on the hip.
Let me check. I do not, but I could definitely add it right now. And
why don't you add it? In the meantime, let's show the audience how our procedure, the Deuk laser disc repair, repairs a damaged disc and makes it pain-free.
Disc injuries are a common cause of chronic back pain. The inflamed annular tear causes back pain. A 1/4-inch sized skin incision is made. A small tube is inserted with no damage to the bones or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own after the procedure, which can take up to 12 months. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922.
Welcome back. You can see from our video how the damaged disc can be so painful. And Henry, did they see how we repair the damaged disc?
Yes, we did.
Using a laser.
Using the laser, correct.
You're looking at the laser, folks. That's it right there at 12 o'clock. The metal tube is the inside of this metal straw that we use to get to the disc. It's called a tubular retractor. It's a retractor because it retracts tissue. It pushes tissue aside. That's what all surgery involves. All surgery involves the use of retractors or tubes or metal blades that actually push tissues aside so the surgeon can get down to where they need to and do their surgery. So retractors are standard in surgery. Tubular retractors are very commonly used in endoscopic surgery. It just means the shape of the retractor is tubular rather than blades. Blades are another form of retractors. In this case, we use a tubular retractor system that the endoscope fits down. It's minimally invasive surgery. This entire surgery, repairing the L4-5 disc herniation that you're watching adjacent to the fusion, this surgery will take about 30 minutes. The patient is asleep for the surgery. You guys can see the herniation right there. It's the blue thing I'm zapping away. The annular tear is the white stuff right here on both sides. We have annular tear on both sides. And I use a combination of laser and metal grabber to remove herniation stuck in the tear and to vaporize inflammatory tissue and get rid of the herniations and inflammatory tissue. All right, we'll take our questions if we have any.
Yes, we do. We have a question coming from Pon Lust on YouTube.
On Lust, welcome back.
Asking, I read that multiple RFAs can atrophy the multifidus muscle. Do you know why this is, and would your procedure have the same risk for that?
Yeah, great question. So Pon Lust is saying that he's read somewhere that doing multiple RFAs can actually cause the multifidus muscle to atrophy. I believe it, but your multifidus muscle will also atrophy because you're having pain, okay? So if you have back pain coming from your facets, you're not actually moving around doing things normally, your multifidus muscle is going to atrophy anyway, right? From inactivity. So how do you determine the difference between muscular atrophy from inactivity because you're in pain all the time versus from a procedure that you're having done to treat your pain? It's not easy to make that determination. But can it happen with a procedure? I imagine it could, but I think it's unlikely to occur with the Deuk plasma rhizotomy. Why? Because all I'm destroying is a sensory nerve, not a motor nerve. We're not destroying a motor nerve. And for those of you who don't understand what I'm talking about, there's really 3 types of nerves in your body, but mostly 2 types of nerves. There's sensory and there's motor, okay? And sensory nerves are responsible for carrying signals, sensory signals from skin or joints or muscles or tissues or organs, up from that organ up to your brain. And then motor nerves are responsible for carrying motor signals to your muscles. So your brain is telling your muscle to contract or move. So those are the 2 basic types of nerves, motor and sensory. Now you have autonomic nervous system, and you have the somatic nervous system, and you have a cranial nervous system. So those are the 3 different types of systems. And those aren't as important to understand right now as the fact that there's motor and sensory nerves. So some nerves carry information to the muscles, causing them to contract. Other nerves carry sensory information from the body parts up to the brain. An RFA procedure is targeting sensory nerves. There is no motor information. So the only way to get muscle atrophy from damaging a nerve is to damage motor fibers, nerve fibers that are destined to go to the muscle fiber. There's a special junction called the neuromuscular junction, and that's where they release a neurotransmitter, acetylcholine, and the acetylcholine causes the muscle to depolarize and through calcium influx at the postsynaptic junction, and that calcium influx causes a depolarization of the muscle, which then propagates along the muscle fiber, and it causes the muscle to contract. That is normal, right? So what happens when you damage a nerve, like an RFA procedure, if you were to cut the motor nerve, you no longer get the release of acetylcholine at the neuromuscular junction. The muscle fibers no longer contract, and they get atrophied over time. They shrivel up and become pretty much non-existent. It's kind of like, think about motor fibers as being like watering your garden. If you have plants in your garden and you don't water them, the plants shrivel up and die, right? Well, the muscle fibers will shrivel up and die also if you don't send them signals to contract. So when you cut a nerve fiber, the muscles will shrivel up and die and atrophy, okay? So you don't want to cut motor fibers ever. But there are no motor fibers in the medial branch of the dorsal ramus, which is the sensory nerve you're targeting for an RFA. So the only way an RFA could cause atrophy of the muscle directly is if the doctor accidentally places the needle somewhere he or she shouldn't, and they accidentally burn your nerve root instead of your sensory nerve. So the nerve root itself has motor and sensory fibers, and those motor fibers travel down to the muscles, to the neuromuscular junction, right? And they cause contraction of the muscles. So basically what I'm saying, long story short, scientifically explained in plain English, is it's not possible, in my opinion, for a properly performed RFA, which targets a purely sensory nerve called the medial branch of the dorsal ramus. It's not possible for that treatment to cause atrophy of the muscle. But people with chronic back pain do get muscle atrophy because it hurts too much to do anything, so they just lay around and their muscles atrophy, especially their multifidus muscle, right? So I hope that explains it to you, but the Deuk plasma rhizotomy does not cause atrophy of the multifidus muscles.
We have a comment coming from Ponlus saying, yes, yeah, that's what confused me too. It's sensory. I think it's sensory. Why would RFA affect the multitudes? I think maybe it's because it heats there many times. Hi, and thank you for your answer.
Yeah, I mean, I don't have all the answers, first of all, right? But I'm trying to make sense of it from my knowledge of neurophysiology, neuroanatomy, and I can't make great sense of it. I don't see why the multifidus muscle would atrophy as long as the patient maintains normal activity levels of a normal human being. Their muscle will not atrophy, even if they have multiple RFAs. At least it shouldn't, right? There is resting tone, which is important. I'm almost done, 5 minutes, Dr. B. And resting tone in the muscles is set by feedback loops that could involve sensory nerves, but usually they're not nerves that come from the facet joints, aka the medial branch of the dorsal ramus. So there are sensory feedback loops that maintain proper muscle tone, but they're typically not reflex loops. They're typically higher order neurons, such as neurons that are located in the brainstem and the pons, and medulla oblongata, red nucleus, cerebellum. Those supramotor neurons, alpha motor neurons, upper motor neurons, if you want to call them, those upper motor neurons are responsible for resting tone of muscles, and those are not local feedback loops. Those are descending fibers that synapse on the alpha motor neurons from the red nucleus in the midbrain, from the medulla, and the motor centers in the medulla oblongata and the pons. So basically what I'm saying is I can't explain why an RFA would cause atrophy of the multifidus. I don't believe it does. I think that's nonsense. There's a lot of stuff that's published today that's just garbage. Nonsense, lies, false, fake. for various reasons. And those reasons are primarily because we have the wrong people thinking through these issues, trying to publish things in medical journals that are not really factoring everything in. So they come to these conclusions that are incorrect and poorly researched and poorly substantiated. The other reason is just corruption, good old corruption. All right, we're pretty much done here. Got a minute left. Any other questions or comments?
Yes, we have a question coming from Lanu on YouTube asking, have you ever heard of Vertiflex procedure? It's for lumbar spinal stenosis.
Yes, of course I've heard of the Vertiflex. It's garbage. It's a horrible procedure. I would never recommend it. It's an interspinous device. Very, very bad idea to put it in. I would never get it done. I would never perform it. It's been around for a long time. All right, we're going to go on to our video of the Deuk plasma rhizotomy for hip pain. So you guys...
I just wanted to say that I've been trying to find it. I think that it's still in development from Tom Bean, but we do have the piriformis and the knee animations. We
don't have the hip yet.
Not yet, unfortunately. I
right,
apologize,
well.
but we will get it very soon.
Yeah, all right. Speaking of which, you need to set up a meeting with Tom Bean.
Exactly. We could set it up this week for sure.
Please do that.
Copy that.
Maybe Friday morning to see his progress.
Yes, sir. Not a problem. We'll do that.
All right, we're done here. Our next patient is going to be a thoracic Deuk plasma rhizotomy, many levels. And yeah, and we're going to be performing the hip DPR on this patient tomorrow morning. So Henry, if you want to stream that one, you can.
Not a problem.
Any other questions?
At this moment, no current questions.
Great. So tomorrow morning, next will be a thoracic Deuk plasma rhizotomy, bilateral T4 to T10, I think, or 12. And then that will be our last case for today. If you want to watch our Deuk plasma rhizotomy, which is a patented FDA-approved procedure for treating facet pain permanently. And then tomorrow we'll have our hip DPR on this patient. And then on Thursday we've got a bunch of cases as well that I'll be doing. All right? Any other questions?
At this moment, no current questions.
All right. Well, we're done. She's going to be going back to her hotel in about an hour. This is outpatient surgery.